So I am Marah Hehemann. I am an assistant professor at the University of Washington in the Department of Urology. My focus is in male sexual and reproductive health, and about half of my practice is spent doing male infertility practice, both at the University of Washington, at our Veterans Affairs Hospital, the VA, and then also at a private IVF center or private assisted reproductive technology center called Seattle Reproductive Medicine, where we have three urologists and one endocrinologist who's a male endocrinologist on staff at SRM. And so this is going to be about trends in male fertility, kind of briefly go over the evaluation and management of men, but also mostly focusing on lifestyle optimization, maybe to help men be able to avoid needing assisted reproductive technology. So I don't have any relevant disclosures. So first, I just want to go over some definitions and epidemiology of male infertility, talk about the approach to the evaluation of the infertile male, including semen analysis interpretation, which is really important, talk about hormonal and other testing, and then kind of put it together as what does this mean about a man's overall health? You know, male infertility may be a window into their overall health. And then I'll talk about managing male infertility with a focus on lifestyle optimization. So the definition of infertility is the inability to achieve pregnancy following 1 year of unprotected intercourse. And we are less stringent about that for older couples who may experience the inability to get pregnant over the course of 6 months. We feel that men should seek evaluation earlier if the female age is older or if there are known male infertility risk factors. And the scope is quite broad. Infertility affects 15% of couples of reproductive age, or over 48 million couples worldwide. Male factor infertility accounts for about 50% of these cases, where it's the sole factor in 20% and contributory in another 30%. So when we take these statistics into account, this equates to almost 15 million men affected by male infertility worldwide. And despite the staggering prevalence, there are several challenges in treating these men. First, so-called male infertility is a very heterogeneous problem. Many cases are incompletely diagnosed or undiagnosed entirely due to barriers such as cultural stigma, lack of medical literacy, and low numbers of specialty providers. Additionally, semen analysis is the cornerstone of male fertility evaluation, and in reality, it is a poor predictive test. So when these factors are combined, it leads to frustration in patients, partners, and providers. And indeed, male partners have long been forgotten in the world of fertility. Public awareness is minimal and reliable resources for men are limited and poorly utilized. Even in fertility advocacy and support groups, they lack support for men. It's mostly focused on women. And the psychosocial impact on men is clear. In a study from a little over 10 years ago, investigators sought to define the impact of perceived infertility diagnosis on 4 specific domains, including personal, social, sexual, and marital. And what they found is that when the cause of infertility is perceived to be the male, the authors found negative impacts in personal and sexual domains. They found reduced self-esteem, distress, and sense of loss are very common. And importantly, a slim minority of men had been evaluated by a urologist, which begs the question, could the care of the male fertility specialist reduce some of these psychosocial stressors? Is education from us, the provider, the key? A 2019 study out of Atlanta argues that yes, education is the key. This is a qualitative study, and it looked at themes that emerge from men in infertility focus groups, including challenges communicating with partners, social isolation, frustration with lack of information, difficulty finding reputable websites, and particularly challenges finding specialists. The men expressed a desire for increased, easy to understand and centralized information, as well as mental health resources. Similarly, a recent study from UCLA looked at social media engagement regarding male infertility. And the authors here found that over 400,000 engagements in a one-year span with just 8 search terms seen here on 4 large social media platforms. So the desire for more information on male infertility is crystal clear. And what do we hear as a male infertility specialist, and I'm sure as in your practice, as you said, with increasing oligospermia and azoospermia, we hear the yearning for more information. We hear things like, what can I do to improve my fertility? Can my diet, drinking, smoking, etc. affect my fertility? Can I take supplements to help? I'm so stressed out about infertility. Is this impacting our success? And the ever-present question, was I born this way? So our goals are to discuss the clinical approach to the infertile couple, which really starts with a concurrent assessment of the couple, so both male and female at the same time. The goals of a male infertility evaluation are to identify potentially correctable conditions, determine the approach for irreversible conditions, and certainly to find life-threatening conditions that may underlie the male infertility, such as testicular cancer. We also would like to identify genetic abnormalities. And then largely, we need to treat them. We need to counsel them on medications, potential procedures, but also lifestyle modifications that may optimize their fertility. And when we look at the AUA best practice statement, so the American Urologic Association does make a best practice statement on the objectives of a male fertility evaluation. And what's key is what's in bold here, that we also need to, we're looking to enhance quality and quantity of life, reduce sequelae of comorbid conditions, and permit the appropriate counseling as to the health of the patient and future children. So really kind of a holistic view. So a recommended male evaluation really starts with the history, physical exam, and semen analysis. And then there are many other different adjunctive tests that I really won't get into today for the sake of time. I'll focus more on kind of this cornerstone evaluation. The recommended male evaluation starts with the history. So first, taking a very careful reproductive history of how often the couple is having sex, timing, duration of their infertility, and prior history of paternity. In taking a male history, I ask very thorough medical history about childhood illnesses, developmental history, current medications, their past medical and family history, whether they have any chemical exposures or exposures to sexually transmitted infections. And then it's also important to understand more about the partner, her age, her prior evaluation. Has she had pregnancies before? Because it may impact your recommendations on assisted reproductive technology or what their options are as a couple. In talking about the male physical exam, it's obviously most critical to do a very thorough genital exam. So starting with the testicles, they should be on average about 18 milliliters, and you're looking for masses and normal kind of texture of the testicles. There has been, of course, published literature on the size of the testicles with the 4.6 centimeters in longitudinal axis being the recommended cutoff for what is considered normal. In examining the epididymis, looking for presence of the epididymis and fullness. When I'm examining the VAS, I'm just looking for, is it present? I examine for a varicocele, whether it is present, and if so, how I would grade it on the scale of 1 to 3. In examining the penis, we're looking for development, whether it's developmentally normal, whether the meatus is normal, or whether it's hypospatic, which may impact the ability of the man to deposit semen adjacent to the partner's cervix. Does he have meatal stenosis, which may impact his ability to ejaculate consistently? A digital rectal exam can be performed to look for dilated seminal vesicles. And in general, other than the genital urinary exam, it's important to look for things like obesity, surgical scars in the groin, gynecomastia, body hair, and a visual field check if you're looking for a pituitary mass. But in actuality, the cornerstone of male fertility testing lies in the semen analysis. And in 2020, the World Health Organization came out with new recommendations, and I'll kind of go over the changes from the 2010 recommendations to 2020. They're modest changes. In asking men to do semen analyses, I have them do 2, and that's guidelines based because of the variability of semen quality from day to day in men. It is best if they're separated by at least 2 weeks, and can be even better if separated by a month, just to take into account any physiologic changes that a man was going through at the time of the first or second test. I do recommend an optimal window of 2 to 3 days of abstinence, and this is all from the guideline from the WHO manual as well. So the WHO makes these periodic releases for laboratory examinations on human semen. The first was published back in 1980 with updates, as you can see here, most recently in 2020. So in 2020, they established these new reference values for human semen characteristics. And these are markedly lower than the ones previously reported back in 1992 and 1987. But it's important to understand how these values are, what the current values are and how they're obtained. So I'm just going to skip forward to this slide. So these values are obtained by looking at the bottom 5th percentile of men who have had prior paternity. So when talking with men about their semen analysis results, I do share with them that there's a caveat that when we say normal, which means that they're within the reference range, there are men that these semen analyses are based on men who have prior paternity. So it's not a perfect test. There are men who have considered normal parameters that may have had challenges with fertility, and there are certainly men below the reference range who have had prior paternity. In comparing the WHO 2010 to 2020, you will see that the changes in the major parameters are very modest. So 2020 parameters from volume, we consider the reference range at 1.4 milliliters, sperm concentration at 16 milliliters, total motility at 42%, and morphology at 4%. That's strict morphology. And I made an error there saying sperm concentration should be greater than 16 million sperm per milliliter. Defining oligozoospermia and azoospermia, or oligospermia and azoospermia, when we consider that the 5th percentile, or the reference range of normal, is 16 million per ml, oligozoospermia is anything below that. And there are sort of subcategories of mild, moderate, and severe. Azoospermia, as you know, means no sperm in the ejaculate, and it can be related to obstruction, where we often find the volume of the semen is low or acidic. And in these men, the testicles are often normal size, they're descended, and you'll find that they have normal hormones with a normal FSH. In non-obstructive azoospermia, the FSH will most often be elevated, and they will often have small testes, but not always. Indications for hormonal testing include abnormal sperm concentration, so the oligozoospermia that I just mentioned, or azoospermia, whether a man has impaired sexual function like ED or low libido, or clinical findings suggestive of endocrinopathy. And it's, in thinking about male fertility, we always have to keep in the back of our mind this map of the hypothalamic pituitary gonadal axis, and how the hypothalamus directs the pituitary, which then directs the testicles, in the following way: by impacting the Sertoli cells and Leydig cells with FSH and LH respectively to produce sperm and testosterone respectively. And to sort of distill it down, and this is what this is sort of the picture that I give to our trainees, is just to think about these two sort of branch points from the anterior pituitary, that the FSH really is the follicle stimulating hormone that's helping produce sperm, and the luteinizing hormone is affecting the Leydig cells to stimulate the production of testosterone. That's sort of the simplest way to think about it, and I think that's helpful for the trainees to grasp. In terms of what testing we order, at baseline, it's important to get a serum testosterone, and this is of course only if they have low, sperm concentration. Not every man really needs this, but at a baseline, serum testosterone and FSH is done as a fasting test in the morning before 9 a.m. If FSH is high, that does suggest impaired spermatogenesis, and if the testosterone is low, you can obtain a repeat total testosterone with a free testosterone, LH, and prolactin. Now, in many cases, just from a practical standpoint, I will get a kind of a full panel of testosterone, total testosterone, free testosterone, LH, FSH, estradiol if a man is obese in particular, and plus or minus prolactin. Most commonly I do that because men prefer not to be stuck many times, and they prefer just to get all of the hormone testing done at once. In terms of genetic testing, when a gentleman presents with non-obstructive azoospermia or severe oligozoospermia, it is recommended to get genetic testing. And in particular, there are two genetic tests that are important. The karyotype, which is looking for Klinefelter syndrome or XXY. In the setting of Klinefelter syndrome, which is common, there are rare foci of spermatogenesis on testicular microdissection in about 50% of men. And so that can inform your counseling of those patients. Karyotypes also look for translocation errors, another genetic phenomenon that can be referred to a genetic counselor. The other important evaluation is the Y chromosome microdeletion. So this is looking at the AZF region, or the azoospermia factor region of the Y chromosome. And in men with AZF-A or AZF-B genetic mutations, they will not be producing sperm. And so at that point, it is reasonable to stop their evaluation because you will not find sperm. And so you can advise them that adoption, use of donor sperm, use of donor embryos may be options for them. In terms of when men are found to have the AZF-C mutation, about 50% of these men will have sperm on micro tessi, and so they can proceed with further evaluation if they wish. The other genetic test that can be done in the setting of congenital bilateral absence of the vas deferens is testing for cystic fibrosis transmembrane receptor mutations. And this test is definitely performed in men where you find on their physical exam that they do not have VASA, or in the setting of congenital unilateral absence of the vas deferens and low volume azoospermia. In men with CBAVD, it should be performed on the partner as well to rule out the potential for having a child with cystic fibrosis and to offer them genetic counseling. So male fertility, the more we know about male fertility, the more we understand that it is a window into their overall health. It can offer us a picture of any present genetic diseases such as cystic fibrosis, congenital bilateral absence of the vas deferens, as just discussed. And also we can find things like DNA mismatch repair, which can cause non-obstructive azoospermia, such as the MLH1, ERCC1, or MSH2 genetic mutations. It also tells us things about their overall health in terms of their risk factors. So as male fertility specialists, we may find that the cause for male infertility is testicular cancer. We've also seen in recent studies from the late 2010s that men with infertility are at higher risk for other comorbidities, such as prostate cancer, cardiovascular disease, hypertension, and this is a marker of oncologic risk in relatives as well. So almost 13,000 men underwent semen analysis, were matched with fertile controls, and 52% of men with infertility had an increased risk of testicular cancer in a first-degree relative. Men with azoospermia were found to have an increased risk of thyroid cancer in all relatives. And men with oligozoospermia were found to have an increased risk of childhood cancer or ALL in their offspring. And indeed, we have seen that based on systematic review, the possible medical comorbidities that are associated with male infertility are either clearly defined or potentially related or sort of unclear. And so multiple studies have indicated that there is an increased risk of testicular cancer, mortality, and comorbid conditions in men with abnormal semen parameters. There have been single study reports of an increased risk of diabetes, multiple sclerosis, chronic epididymitis in men with abnormal semen parameters, and it's a little less clear, but there is a suggestion that there may be an increased risk of prostate cancer, melanoma, other cancers, sexually transmitted infections, or thyroid disorders in men with abnormal semen parameters. And I do think it's important to talk to men about these overall risks, especially if they have conditions related to their infertility that you cannot truly change. It's important to tell them that they may have these increased risks, and it's important that they follow with a primary care doctor and have regular health screening. So in the setting of this increased risk, how may we optimize fertility and longevity? When we describe the so-called flexible aspects to fertility, patients and researchers have many questions. And so can we make a case for these areas of lifestyle modification to improve not only fertility, but overall longevity as well? There are some challenges in male infertility research, and this will come up in the studies I'll present on lifestyle modification. Male infertility research is difficult to study. There is often no control group and difficult to randomize. Studies are subject to recall bias when they're retrospective, and the effects on the semen analysis. So many studies will look at how lifestyle changes affect a semen analysis, but this may not extend to fertility. So truly affecting pregnancy and live birth, which is the gold standard of what we're really looking for. Many of these studies have poor quality evidence, and those are limiting factors to lifestyle modification studies. So the first potential modifiable risk factor for male fertility is diet. In general, most studies will focus on nutrients or diet styles or food classes and how they impact semen parameter outcomes. Studies focusing on pregnancy rates and live birth rates are very rare and significantly harder to achieve, as I mentioned. Additionally, the many studies that we have in this area focus on young male, healthy male volunteers rather than men presenting with infertility. So it's difficult to generalize them to men with subfertility, which is our primary population. But that being said, there are many studies in this area. In 2020, a Harvard study of almost 3,000 young Danish men looked at the effect of the Western diet compared to 3 other dietary patterns, including the prudent diet, a pattern consisting of mostly vegetables, fish, and lean meat, a Danish diet, which is kind of an open sandwich predominant diet, and a vegetarian pattern. The author found significant improvement in sperm concentration and total motile sperm count in men eating the prudent diet for the longest, while consumption of the Western diet was found to be associated with the lowest total motile sperm count. And importantly, the vegetarian diet trended towards improvement in total motile sperm count. Interestingly, in an older study by the same group comparing the prudent and the Western diets, the authors actually found that there was no difference in sperm concentration in men consuming Western diets and those consuming prudent diets. So there was a significant difference in progressive motility, highlighting again the limitations in these studies. In 2019, a similar study was performed looking at adherence to a DASH diet, so kind of a low salt diet for 1 year, and the correlation was semen quality. When compared to the other two diet types, the DASH diet, which is primarily used for patients with hypertension, was the only diet which showed significant improvement in semen parameters, including sperm concentration in the leftmost column, total sperm count in the middle column, and importantly, total motile sperm count in the right column. The effect of the DASH diet on total motile count became more pronounced and statistically significant with a greater duration of adherence to the diet. And indeed, another study swapping out processed red meat for fish was associated with significantly higher total normal sperm count. But what do all of these dietary changes mean clinically? Well, when clinical outcomes were examined in the relationship of type of meat consumed, including high amounts of processed meats, correlated with worse fertilization rates in conventional IVF, but no effect was found with intracytoplasmic sperm injection. Across the various types of diet, meat consumption showed no significant difference in implantation, clinical pregnancy, or live birth rate. So as much as we want to counsel our patients about how these dietary factors may impact their semen quality, at the end of the day, assisted reproductive technology may supersede the impact on sperm counts. So therefore, our takeaway here is that long-term use of a diet in whole grains, fish, fruits, and vegetables may improve semen parameters, while adhering to a Western diet high in red meat, processed meat, or high in sodium and dairy may be detrimental to semen parameters. But major clinical outcomes using assisted reproductive technology may not be affected by diet. So next, let's see how exercise and obesity may impact fertility. In a 2015 study of 1,200 healthy young men, semen parameters were correlated with hours of television watching daily and activity level. As you can see in this table, greater hours of television per day, as you look down the table, was associated with significantly lower sperm concentration and counts. This is also graphically represented here with hours of TV per day on the x-axis and sperm concentration and total counts on the y-axis, so seeing that improvement. Furthermore, the authors found an effect modification of self-reported fitness level and television watching on sperm concentration and counts, with the men exercising more having better semen parameters despite higher amounts of television. So there are several studies, two of which are highlighted here, that support more physical activity and less sedentary activity as correlated with better semen parameters in healthy men. However, how does exercise impact men presenting with infertility? And what about the degree of activity? What about the clinical outcomes? In a cohort of over 200 men presenting to a fertility center, higher levels of moderate to vigorous activity were related to higher sperm concentrations. In the multivariable model, men in the top 3 quartiles of physical activity had 10, 30, and 43% higher sperm concentrations than men in the lower quartile. And physical activity trended towards positive association with total sperm counts. When separated by activity type, greater time spent in outdoor activities and weightlifting was associated with higher sperm concentration. Specifically, men performing the most outdoor activity and weightlifting had 42% and 25% higher sperm concentrations, respectively, than the men with 0 hours per week. In contrast, bicycling was inversely associated with sperm concentration. So it is unfortunate for all of our Peloton and bike fanatics out there, but that may be detrimental. But perhaps the most important aspect of this study was the clinical outcomes portion. The authors found no association between time spent in moderate to vigorous activity or sedentary activities to clinical pregnancy or live birth rate following intrauterine insemination or IVF. Regardless, I do think it's a very valuable tool for our overall health. It just may not impact men who are using assisted reproductive technology. The other question we must ask, though, is there such a thing as too much of a good thing? So these investigators performed a randomized controlled trial of moderate versus high intensity exercise for 60 weeks, 120 minutes a day, 5 days a week. In this figure on the x-axis, you see the weeks in the running phase, followed by the weeks in the recovery phase. And sperm count, concentration, morphology, and motility are on the y-axis respectively. So high intensity runners are represented by the black dots, and moderate runners are represented by the white boxes. So as you can see, the groups of very high intensity runners had a significant drop in their total sperm counts, concentration, motility, and morphology from baseline, and lower counts and concentration than the moderate intensity exercises across the board. So importantly, though, all of the parameters recovered entirely after 36 weeks in the recovery phase. So these data suggest that extreme amounts of cardio exercise may be detrimental to semen quality, perhaps due to stress on the hypothalamic pituitary gonadal axis. So in summary, reducing sedentary activity and increasing low to moderate physical activity may improve semen parameters, while consistent high intensity activity has a reversible adverse effect. ART outcomes with ICSI may not be affected by activity. And while on the topic of exercise, I do think it's important to discuss this meta-analysis from 2015, which assessed the impact of obesity upon semen parameters and reproductive outcomes. So 30 studies were included, and outcomes included both clinical and laboratory in nature. The clinical outcomes were likelihood of infertility, in vitro, embryo development, clinical pregnancy, live birth, pregnancy viability, and infant development. The authors found that obese men were more likely to be diagnosed with infertility with an odds ratio of 1.66. Men who reported being obese as young adults had a lower relative risk of having a child by age 47. And live birth rates did decrease significantly for obese men versus normal weight men with an odds ratio of 0.65. So the takeaway here is that reproductive potential of obese men is reduced relative to that of normal weight men. In particular, diagnoses of infertility, live birth rate from ART were higher and lower respectively. So moving on to recent data on fertility and generalized supplements, as these are highly marketed to men and couples experiencing infertility. And luckily, there are some very recent and well-designed studies with important clinical implications. Zinc and folic acid have been recommended as fertility aids, given the essential roles they play in spermatogenesis and DNA synthesis. These authors designed a multi-centered, double-blinded, randomized, placebo-controlled trial to evaluate live birth and semen quality. Approximately 1,200 men were randomized to each arm, and adherence was high. In total, 35% of the couples enrolled attained live birth, with no difference found between the intervention group and the placebo group. And there was also no difference within the infertility stratum, meaning whether the child was conceived by IVF, IUI, ovulation induction, or some other treatment strategy. When it came to semen parameters, there was no difference in the major parameters, but there was a significant increase in DNA fragmentation in the treatment group. And so they concluded that zinc and folate did not improve live birth rates or semen parameters and actually worsened DNA fragmentation index, which I don't think that they were expecting to find. The MOXIE trial is another recently published supplement trial. This time they looked at a mix of antioxidants formulated versus placebo. And so you can see the mix of vitamin C, vitamin E, and many other different antioxidants that were compared to placebo. The primary and secondary outcomes were live birth and pregnancy, and semen characteristics were also compared. In the pilot study of 171 participants, no difference in live birth rate or pregnancy with or without intervention was found. So enrollment was stopped due to failure to reject the null hypothesis. They did evaluate the semen parameters in the men at 3 months, and the antioxidant group actually had a decline in sperm concentration, total sperm count, total motile count versus improvements in the placebo group. And the authors concluded that antioxidant supplementation does not improve pregnancy or live birth rate. In another recent evaluation of the impact of fish oil supplementation on testicular function, which has been, this did receive a lot of press when it first came out, the authors examined semen and serological data in men reporting use of fish oil versus those who had no fish oil use. So this was a retrospective study, which is subject to recall bias because this was self-reported. Users of fish oil were found to have greater semen volume, testicular volume, sperm counts, lower gonadotropins, and higher free testosterone to LH ratio. Unfortunately, as I mentioned, the study has many limitations and doesn't study the clinical outcomes such as pregnancy and live birth. So our takeaway on supplements in male fertility is that there is level 1 evidence that confirms that there's no improvement in live birth rate or semen parameters with zinc, folate, or antioxidant therapy. And there's poor evidence for fish oil improving testicular function. And I definitely share this with men because many, many times men are asking about supplements. So moving on to a topic which can be particularly hard to address, but's important to discuss, because psychological stress is known to affect the neuroendocrine system, including the hypothalamic pituitary gonadal axis. Thus, many researchers have tried to answer the question, are stress, anxiety, and even infertility itself further risk factors for impaired male fertility? A group of Italian researchers studied the impact of anxiety on semen parameters in men approaching their first cycle of IVF. All subjects completed questionnaires measuring state anxiety and trait anxiety, which are sort of defined here. So state anxiety being a transient emotional condition, and trait anxiety being more of a personality trait or temperament or how a man may react to situations with high-level emotional responses. Compared to patients with low state anxiety, patients with high state anxiety had lower sperm concentration, count, motility, and DNA fragmentation indexes. Similar findings were true of high versus low trait anxiety. And so the authors concluded that high levels of either type of anxiety are associated with worse semen parameters. Another study in 2014 evaluated 70 men for work and life stress, which were both objective and subjective, using validated instruments. Work stress was found to have no association with semen parameters. However, as seen in these scatter plots, perceived life stress was associated with a decrease in sperm concentration, which is in the upper left, motility in the upper right, and normal morphology in the bottom scatter plot. So in summary here, men with high life stress or anxiety may have worse semen parameters, likely due to neuroendocrine alterations, and should be referred to counseling appropriately. Now, unfortunately, the outlet for many men with stress and anxiety can also impair fertility. We all know that opioids inhibit the GnRH release from the hypothalamus and cause downstream effects on the pituitary gonadotropins and testosterone, which then results in hypogonadotropic hypogonadism. Additionally, in animal models, when exposed to morphine, spermatogenesis was hampered, causing a reduction in cell counts and in all stages of spermatogenesis. Similarly, cocaine-exposed rats demonstrated disruption of spermatogenesis with disrupted tubules, cellular degeneration, sloughing, and vacuolization as seen on microscopy and electron microscopy. Marijuana is a very hot topic, and cannabinoid receptors are certainly expressed beyond just the CNS. They're found in the reproductive organs, including on spermatozoa. In vitro studies demonstrate the detrimental effect of marijuana on sperm motility and the acrosome reaction. However, the evidence of overall effect on semen parameters and fecundity in humans is mixed. A small 2014 study showed that marijuana use 3 months prior to semen analysis doubled the risk of poor morphology, but a larger Danish study revealed that routine use of marijuana was associated with a 30% reduction in sperm concentration and sperm count. So different parameters were affected in these studies. Now, on the contrary, a large study from Harvard recently confirmed that a significantly greater proportion of marijuana never smokers than ever smokers had abnormal sperm concentration, motility, progressive motility, and total sperm counts. In our recently published data from the University of Washington, 409 men were evaluated at our Men's Health Center and Male Fertility Lab. Semen parameters were associated with marijuana use status. And in a multivariate logistic regression analysis, we found that current and past marijuana users had an increased odds of abnormal strict morphology. Current users had increased odds of abnormal semen volume and trended towards increased odds of abnormal total progressive motile sperm count. Current users, however, had reduced odds of abnormal motility. This area is difficult to study due to variable legalization across states in the United States and limitations in understanding the dose-outcome relationship in this fairly unregulated substance. And so these are inherent, and of course there are inherent limitations of retrospective studies. So until we have better data with clinical outcomes, in my opinion, the jury on marijuana and male fertility is still out. So to summarize here, we know that opioids turn off the HPG axis, causing hypogonadotropic hypogonadism. This is particularly important as the opioid epidemic continues to plague at least the United States and probably more broadly. And similarly, cocaine may have negative impacts on spermatogenesis. Marijuana may be protective for sperm motility, but overall the data is mixed and difficult to study with no major clinical outcomes having been examined yet. For the sake of time, I won't review the studies that demonstrate the negative impacts of smoking on male fertility and fecundity or the detrimental effects of excessive alcohol use, but certainly I do discuss with patients minimizing these risks when discussing lifestyle modifications. The last kind of topic I'll talk about here is just the use of excessive androgens. Men taking exogenous testosterone are common. At least in the United States, there are, in every big city, there are dozens and dozens of male shot clinics or male testosterone clinics where men receive prescriptions for testosterone on a self-pay basis and oftentimes without adequate counseling on how this may impact their fertility. This also occurs with illicit anabolic steroid use for bodybuilding, but I often find that more it's just guys, seeking out help and being improperly counseled by these shot clinics. use of exogenous androgens results in low FSH and LH level and abnormally high testosterone. So on screening tests, on the semen analysis, most likely men on testosterone will be azoospermic. And then when you look at their hormones, you'll see this extremely low gonadotropin level and very high testosterone level. So exogenous, how does this impact spermatogenesis? Exogenous testosterone leads to decreased intratesticular testosterone production because it shuts down the production of gonadotropins, and partial or complete suppression of spermatogenesis. And men can be very confused that they were not counseled appropriately by these clinics. So now we have discovered that each and every one of these topics has a growing body of evidence regarding the impact of fertility and fecundity, and some evidence is much stronger than others. So how do I advise men who ask me about how they can optimize themselves? And I definitely discuss the limitations of these data with patients. Regarding a diet, I encourage men to eat a healthy, balanced diet focused on the Mediterranean style, sort of lean proteins, lots of vegetables, whole grains as the primary source of nutrition. I encourage men to exercise 30 minutes a day, 5 days a week, just a moderate, light to moderate exercise, and to maintain or obtain healthy weight. I talk to them about the studies on supplements and that there may or may not be a benefit, and the level 1 evidence showing that there's probably not a benefit. But I do think that for folks with dietary deficiencies, like folks in Seattle, most of us have vitamin D deficiency because of lack of sun for months and months, to supplement these dietary deficiencies. Regarding stress and anxiety, I encourage men to practice mindfulness, meditation, or to seek out counseling if that is playing a role. I encourage men to reduce or quit the use of recreational or illicit drugs, particularly the illicit drugs. And that can be certainly challenging, especially for men who are on rehab-related drugs, which are still opioid and can have the similar effects to the illicit opioids as well. I encourage men to reduce or quit smoking tobacco. And there's recent data on vaping and that really impacting male sexual function. This came out just this week. And vaping, I do also counsel on reducing. I think alcohol can be used in moderation. And certainly when men are on testosterone replacement therapy, I encourage them to speak with an endocrinologist or a reproductive andrologist like myself about how to transition off. And we have some strategies for that. It's important to let men know that any changes they make to their lifestyle may take 3 to 6 months to impact semen parameters, because that is the lifespan of the overturn of a sperm cell. So they need to know that it won't be immediate. So with that said, that is my general guideline to how I approach the male fertility evaluation and counseling on lifestyle. There are obviously the more medical pieces to our practice in terms of hormonal modification, surgical treatment of male infertility, and I'm happy to answer any questions on all of that too. But for the sake of time, I wanted to focus here on how we can just improve male fertility and longevity. So thank you so much for the opportunity again from IVU, and for the attendees, thank you so much for attending, and it's always an honor, and I look forward to these talks and hopefully meeting everybody in person at some point in our lives. So thank you for being here.
Thanks, Dr. Heeman. I believe Dr. Kutesa had a question about fasting in the chat.
Okay, can I see the chat? Oh, fasting. The fasting testosterone, it optimizes the testosterone level, and that is an optional piece. I tell men that it may give them the optimal result. If they can't fast, many of them can fast because it's so early in the morning. But if they can't, it's okay. I don't think it hugely impacts the testosterone. But certainly my endocrinology colleagues recommend that they fast. Thank you for the question. Do you, just to ask a question of the attendees, do you hear men asking these questions about how they can improve their lifestyle regarding fertility?
Yes, in my experience, many of them ask, what can I do to improve? They ask about diet and exercise, and you've covered them very well.
Yeah, I think especially for men who don't have, who have clear abnormalities on their semen analysis, or even if they don't, and they are struggling with fertility with their partner for idiopathic reasons, men really want to know what they can do. And so I think it helps just to have in our arsenal things to kind of guide them on. So yeah, and I just generally give them the guidance that anything that's good for your heart is good for male fertility.
Yeah, I have a few more questions. You talked about testosterone replacement. There are some men who have erectile dysfunction and low testosterone levels, and they are on treatment. But in order not to impair fertility, how long do you replace their testosterone if it was for erectile dysfunction?
If they are trying to get pregnant, I would have them stop the testosterone. In the setting of being on prior testosterone use, men are curious, so I do talk to them about the fact that this testosterone that they've been on will suppress, it basically is a male contraceptive. So it suppresses spermatogenesis, and that regaining sperm production may take time, or it may not be possible in some men. And there are two main predictors of whether a man will regain sperm production after being on testosterone. One is a man's age. So older men have a lower chance of regaining sperm production, and the second is how long he has been on the testosterone replacement. So men who went to one of these clinics or started testosterone for testosterone deficiency only 6 months ago will have a greater chance of regaining sperm production after stopping T than a man who has been on testosterone replacement for 10 years, because the longevity of being on testosterone impacts the pituitary and can really sort of shut down the pituitary's ability to produce its own LH and FSH in the future. And there are a few different strategies of the medications we provide when they're coming off testosterone to help sort of boost their own testosterone production and boost sperm production. But I do counsel them that they probably will not feel as good as they do feel on testosterone.
Okay. What about vasogram? Do you do a lot of those, or you just biopsy the testicles?
With kind of a clinical picture of non-obstructive azoospermia, or if they look like if they have obstructive azoospermia, I don't really do vasograms. In that setting, it would be our practice just to do a testicular sperm retrieval and then have that sperm be used for in vitro fertilization.
Pardon, that is for the obstructive type. You just do the test here?
Right, exactly. Unless, so in the setting of obstructive azoospermia, it can be hard to differentiate in some men, especially when we're practicing mostly telemedicine and we can't examine the men for their vasa. They can be obstructed due to ejaculatory duct obstruction, and that can be fixed by resecting the ejaculatory duct and then allowing them potentially to ejaculate sperm again. In the setting of bilateral absence of the vas deferens due to cystic fibrosis, CFTR mutation, we would go straight to TESA for them.
Okay, I have two more questions.
Sure.
Sperm banking, have you done it for younger people? If someone has a solitary testicle, they're going for chemotherapy, what is the lowest age you've recommended sperm banking?
So they have to be pubertal. They have to be, and generally you can tell if they can bank sperm by if they're having nocturnal emissions, and they're able to masturbate.
Okay. And then the prostatic midline cyst, which could be seen by sonographers on a transrectal scan, what size do you think is significant? Sometimes we've seen a small cyst as small as 6 millimeters, and we don't know whether to go resect the ejaculatory ducts or up the roof of the cyst or leave it alone.
I think, yeah, it's interesting. I've seen a lot of prostatic cysts recently. I don't know, what's going on, but I've seen a lot of them lately. So that's definitely challenging because when they're so small, it can be really hard to find them, to unroof them. And so recently I actually did a procedure where I did a concurrent transrectal ultrasound while doing the resection to kind of guide where I was going. And you can actually use a transrectal Chiba needle to get into the cyst and sort of expand it with fluid, or using methylene blue so that when you resect it, you're in the right spot. So that's one potential option. In terms of indications to do a resection, I think if they're having true obstructive oligospermia or azoospermia, in order to give them a chance to avoid IVF, which is, as we talked about at the beginning, very costly, and to give them the chance to ejaculate sperm again, I do think that it would be valuable to try to resect and try to, relieve the obstruction.
Okay, thank you. Those are my questions. I don't know whether Dr. Job, Dr. Nasanga, whether you have more.
Yeah, hi, I posted a question concerning what the experience. Sorry, I got a call in between there. I went off, but what's your experience with varicocele as that for the patient, do they all reverse? What's your experience with varicocele as a cause of male infertility?
Yeah, so that is a great question. Very important part of the physical exam in men with any semen parameter abnormalities. And in sort of just following the guidelines from the American Society of Reproductive Medicine, if men have semen abnormalities and are found to have a varicocele, I do recommend fixing it. The data, and I'm happy to, do another lecture anytime on the medical and surgical treatment of male infertility. The data is really substantial on how fixing varicoceles can help men, not only just improving the semen parameters, but improving true clinical outcomes of pregnancy and live birth with either having intercourse and getting pregnant, using intrauterine insemination or even from IVF. So even if a man is going down the road of IVF, I do counsel them that it can improve outcomes, and that may have something to do with how varicoceles impact DNA fragmentation in sperm. And the approach is I use as a microsurgical subinguinal incision, and we do a lot of varicocele treatment just because they're so common, and so common in men presenting with infertility. I hope that answered your question.
Yes, thank you.
Yeah, thank you.
Well, thank you, Dr. Heeman, for your time. It was such a wonderful lecture. And thank you, Dr. Kingogo and Dr. Kutesa for coordinating. And I hope everybody has a great weekend.
Thank you.
Yes. Good.
Thank you all
Good
so much
weekend too.
for coordinating and for being here. And I truly do hope to meet you at some point.
Yes, thank you for your time, Doctor.
All right, take care. Have a nice weekend.
Bye, everyone.
Yes, to you too.
Bye.